So, welcome to the Transplantation podcast. I'm your host, Dr. Macy Levan, the social media editor for the Transplantation Journal. This is a podcast where we go behind the research and talk with people who did the work. Today, we're discussing a paper in Transplantation titled Travel After Transplant: Demographics, Travel Trends, and Vaccination Practices of U.S. Immunocompromised Travelers. As more people receive solid organ and stem cell transplants and live longer after them, international travel is becoming a bigger part of life after transplant. But immunosuppression changes infection risks and can complicate things like vaccines and pretravel counseling. To unpack this, I'm joined today by Dr. Robert Rolfe, an infectious disease specialist and lead author of this study. Thanks so much for joining me. Can you tell me your name and where you work and what you do?
Yeah, so I am Robert Rolfe. I'm an assistant professor in infectious diseases at Duke University. I'm originally from South Carolina, and I did my medical school training at MUSC in Charleston, South Carolina. Then I was out in Birmingham, Alabama for internal medicine residency. While there, I did some global medicine work, so some trop med training when I was in Lima, Peru, and then after that came to Duke for both infectious disease and med micro fellowships. And so when I joined faculty in 2022 with that trop med training in the past and an interest in global health and travel related infections, I was felt to be the correct person to kind of restart the Duke's Travel Clinic. And so I restarted that when I joined faculty in 22. And so with that, early on started seeing a lot of patients with history of organ transplants or stem cell transplants. And so it was a patient population I was interested in kind of learning more about. And I joined the Global Travel EpiNet, which is a consortium of mostly travel clinics within the United States that is run by Regina LaRocque and Ed Ryan at Harvard. And so with that group was able to kind of learn from them and Camille Cotton as well on kind of the management of these patients and were able to kind of research kind of how these patients have been managed in travel clinics across the country. And so that's what sparked my interest and kind of where we started with this project.
Wow, you definitely have the background for all of this. You're the perfect person. So let's start with how you did the study and what you actually found about transplant patients who are traveling. So you said you worked with this global Travi Epi network. Is that how you would say
Yeah,
it?
G10 for short is what we call it.
G10. Okay.
Mhm.
And that's what, 17 US pre-travel clinics?
Right. So it's
Okay.
17 different health systems in particular were what we used for this analysis because they were the ones that have been seeing patients with history of transplantation.
And your study ranged 15 years, right? So from 2009 to 2023, you had data on 317 immunocompromised post-transplant travelers,
Right.
and you
Yep.
compared them with over 3,000 matched controls without a transplant history,
Correct.
right?
Yep.
And then you looked at where they traveled and what vaccines they received or did not receive at those clinics.
Right. So that was kind of the primary interest was how vaccines were managed in this population, but also we wanted to see were there trends, like what type of travel were they doing, and then where were they going, what type of places were they staying as well. So, the G10 was set up originally by Doctors LaRocque and Ryan back probably in 2009 when they started collecting data. And so for patients seen within this network at their pre-travel visit, both the patient has pre-filled out a survey or questionnaire on what are they going to do during their trip and what's their medical history. And then that's reviewed during the clinic visit, and additional data is put in by the provider that sees them. So, what vaccines were given, and if there were vaccines that seemed like they were indicated based off the itinerary, that weren't given, why weren't these vaccines given? And so there were several different options for answers for those as well. And so we were able to look back at all the data that this network has had since the beginning.
Wow. So can you back up for just a second and walk me through, and everyone in simple terms, Who counted as an immunocompromised post-transplant traveler in your study?
So we were interested in two groups in particular. So anyone with a history of a solid organ transplant that was still on immunosuppression. So if someone had had a kidney transplant that had failed and were back on dialysis and no longer on immunosuppression, that person would not be in our cohort of interest for the study because we wouldn't still consider them immunocompromised. And so that was the solid organ side of things. From the stem cell transplant side, anyone within 2 years of their stem cell transplant, we still considered to be immunocompromised. So those were in the cohort, but then also anyone that was after or was further than 2 years out from their stem cell transplant, but still on a medicine that was considered immunocompromising. So those were the kind of two sets that we combined for this data in
And
particular.
and what does a typical global pre-transplant, or I'm sorry, pre-travel clinic visit look like? So what does this look like? And and how are things like the destination, the purpose of travel, and vaccine decisions captured? I think you mentioned it's on a form, but what does that visit look like?
Yeah, so during a typical visit, at least what I do personally is first we'll review with the patient to what's their experience with travel been in the past. So are they from the United States or are they from somewhere else? And do they have a history of infections associated with travel as well? And then if they've been on malaria prophylaxis, what's their experience been with that before? And then getting some gauge on vaccine history as well. Then talking about their medical history. And so for patients with a history of transplantation, knowing if it's a solid organ transplant, what's the rejection history like? And so have they had issues with rejection? Or is this a very remote transplant that everything seems really stable? So two very different populations. And so some gauge on what how immunocompromised are they, and then how stable does that underlying immunocompromising condition seem to be? And so then after that, going through in detail with them, what vaccines have they had before? Ideally, they'd bring in prior vaccine records as well. In North Carolina, we're able to check like a vaccine registry. If someone's given a vaccine at a local CVS, we're able to pull that in as well. But that's different state to state, I believe. And then after reviewing that, talk specifically about their itinerary. And so go through what activities do they have planned, what's their purpose for travel, and then what countries are they going to, how long are they going. So I like to use maps a lot in my visits, and so kind of we'll plot through on a map with someone where they're planning to go during the trip, especially when looking at malaria endemic areas. And so kind of seeing what those maps look like during the visit itself and the yellow fever endemic areas. Um, so people will kind of self-select for um, so sometimes this happens where people will self-select for visiting countries that require yellow fever vaccination because that's a vaccine that can only be given in sites approved by the state, and so that's a kind of high bar, and so CVS and Walgreens generally, at least in North Carolina, don't have that ability to give the yellow fever vaccination. So those patients
Hmm.
in particular are coming to travel clinics. So probably see more people that are going to countries with those requirements just because of that requirement itself.
That is very interesting. I remember getting the yellow fever vaccine before my first trip to Brazil
Yeah,
in 2018. I think I got it at a Publix grocery store in the Richmond, Virginia suburbs.
really interesting.
Yeah,
Yeah,
interesting. Yeah, so it's state to state that where you can get it, huh?
right.
Interesting.
Usually it's local health departments and then kind of authorized clinics are the two, and you'll get a yellow card with it as
Uh-huh.
well. Yeah,
I have the yellow card. I didn't have to get another one yet. I've been back to Brazil 3 times since then. So,
yeah.
um, all right. So this study, let's talk about what you found, right? So you found that more than 146,000 pre-travel consultations, there were only 0.22% were post-transplant travelers. So it's a small but very important group. I think you found that the median age was 54 and 45% were women. So, compared with other travelers, they were more likely to travel to Central America, the Caribbean, and Europe, and less likely to go to Africa, South America, or Southeast Asia. I read that you also saw more that were visiting friends and relatives, about 16% versus 6% in the control group, and more cruise travel, so 13% versus 8%. So, when you looked at where and why transplant recipients were traveling, what surprised you the most?
I think that the percent of people going to visit friends and relatives overseas is probably the thing that surprised me the most. And then the overrepresentation, or the higher amount that were going on cruise travel as well. So wasn't really expecting those going into the analysis, but then I thought both were interesting. Even though leisure still was the primary uh, reason for travel for both the transplant population and the non-transplant population. The cruise travel and the visiting friends and relatives were interesting points there. And after the fact, thinking through it, could think on kind of reasons why if someone's originally from a place, they're probably going to want to go back there, and so that's not going to be different if they have a history of transplantation or not. And so, kind of logically would make sense to me why that population was in there. The cruise travel, we talked kind of among the authors, why were we seeing this as well? And there were kind of two different thoughts, which we mentioned both in the discussion. But in the past, we were wondering, was cruise travel seen as like a safer option for people? And were transplant patients or people with history of transplantation going on cruise travel because they viewed it as a safer means of travel instead of just uh, flying somewhere and then staying locally. We point out that it's probably actually not a safer form of travel. Just COVID. I think everyone saw kind of how that went around on cruise ships, but diarrheal infections can as well. And so our other thought was maybe um, most people going on cruises, it doesn't reach that threshold for them to feel like they need to seek out a travel clinic to get advice from a kind of travel medicine specialist, whereas a patient with a history of transplantation, regardless of which type of travel they're doing, may be more likely to present to talk to a specialist in this topic as well. So maybe that's why we were seeing more of the cruise ship travelers too. But again, all this was supposition because we couldn't go back after the fact and ask these people or compare to people that weren't within this cohort. But it was an interesting finding nonetheless, we thought.
Yeah, I have that noted. Like, so people see cruises as safer, but, does that perception really line up with the risks that they face from your perspective?
Yeah, it doesn't really seem to. So, especially the diarrheal and respiratory infections, just like I said, with COVID, I definitely see people coming back from cruises with GI issues as well, and then just nondescript respiratory illnesses, not COVID, but others too, that they've gotten while traveling.
So, on the vaccine side, you looked at both routine vaccines and those travel specific vaccines, but no post transplant travelers in your cohort received the MMR vaccine. Is that correct?
Correct. Yes.
And only one received yellow fever vaccine, despite some itineraries that could involve exposure.
Right. So that was one of the big things we were looking for in this study, because our post-transplant population that we were looking at in particular is all considered immunocompromised. These
Mhm.
live vaccines are actually contraindicated, and so like correctly, none of these patients seem to be getting vaccinated. But we were really looking to see were sites, either overlooking that history of prior transplantation or vaccinating despite this, just given patients' itineraries, and we didn't see that within the cohort.
Typhoid vaccine, right,
Yes,
was actually used more often in the post-transplant group, while rabies pre-exposure vaccination was almost never used, and only one transplant traveler received it, even though it's an inactivated vaccine. Can you tell me what that means? What's an inactivated vaccine?
Yeah, so kind of the big categories here would be either live or non-live vaccines. So inactivated here, really just referring to any type of non-live vaccine. And for live, there's even a subset between replication competent and not replication competent. But really here, the big differentiation was just that live or not live. And so live vaccines are ones that theoretically someone could have a viremia associated with them. An immunocompetent host should be able to clear that viremia, although it still does carry risk. Like the yellow fever vaccine itself, there's a risk of about 3 in a million for travel for immunocompetent people under the age of 60 that they could get this side effect called a viscerotropic disease. So yellow fever associated vaccine associated viscerotropic disease. And what that is the person pretty much gets a syndrome that looks like yellow fever. So it can cause liver injury, liver failure, or even death as well. Again, that's rare in that 3 in a million range, but that is related to that viremia, where you worry that in someone that's immunocompromised, they're not going to have that immune system response or immune system that's capable of kind of controlling that attenuated or weakened strain of the virus itself. And so that risk may be higher in that group. And so, yeah, sorry.
So, what do you think's driving like no one to get the rabies pre-exposure vaccine, or none of those post-transplant travelers have the MMR and only one got the yellow fever? Is it that, three and what did you say, a risk? Is it
Yeah.
the risk? Is it awareness? Is it cost? Is it timing or other competing priorities?
So with rabies, I definitely think it's a cost issue. So only one would received vaccine, but I think there was somewhere around um, 20 maybe who had been offered vaccination. So 23 who declined vaccination, and then 12 who didn't get the rabies vaccine because they had insufficient time. It's recommendations have changed in the past 5 years, but used to be a 3 dose pre-exposure series with doses given at 0, 7, and then 21 to 28 days. Now it's a 0, 7, and somewhere between that 21 days and 3 years. So most people are just getting 2 doses. Regardless, it's a pretty expensive vaccine for most people. So, uh, you know, um, out of pocket, those numbers typically range in the $500 range
Oh,
for per dose. And so when you're looking at either $1,000 for a series or $1,500 for a series, that's a lot to kind of put on a patient that's already having to pay for their trip themselves. And that's traditionally not a vaccine for pre-exposure purposes that's covered well by insurance.
interesting.
Yeah.
So let's talk about some clinical implications and the patient perspective. We just mentioned the cost of some of these vaccines, but you know, a lot of patients want to travel after transplant. They get a transplant, they receive the gift of life, and they want to live their life. And I'm sure that we want to encourage that. But one of your key messages for clinicians is that transplant teams and pre-travel clinics need to connect earlier and more deliberately, especially when live vaccines like MMR or varicella could be given before the transplant. Um, if you could change one thing about how transplant teams approach travel, what would that be?
So I think it would be just routine, be more mindful about routinely asking questions around travel, future travel plans to patients, especially those that are from another country or in a country that may be even endemic for yellow fever, because there's a lot of issues around documentation when traveling back to potentially their home country, and so really just identifying them early. And so hopefully things could be, vaccines could be given pre-transplant, because I really think that even if you identify someone after transplant and you're able to give them some of the inactivated vaccines, there's theoretically some risk that immune response is going to be blunted in that setting as well. So, even outside of the MMR, which I think is important for everyone to check, even if they're not traveling, knowing kind of yellow fever vaccination status, depending on future travel plans, would be important as well.
So you mentioned the MMR, and in your study, only 84% of transplant travelers had that documented MMR immunity. So
Right.
given these rising measles, incidents that we're seeing and the fact that most of the US cases are linked to international travel, how worried should we be about this gap?
Yeah. I think epidemiology of this is always changing. Now I'd say most cases are probably linked to local spread, just with the numbers from the past year. But traditionally or historically, definitely most of the cases were kind of travel related. And so I do think most transplant groups do a very good job at documenting vaccination status for MMR beforehand, but I think that's an important one to talk through with patients too before a transplant, just to get their sense of are they willing and open to vaccination if they don't have that documentation as well, because after transplant things get a lot harder and there's a risk even for those not traveling about measles infection now.
Right. So, how realistic is it to systematically ask transplant candidates about future travel and use that to plan some pre-transplant vaccination strategies?
That's a good question, and I think that's one where we could probably within travel medicine we could collaborate well with kind of transplant teams too to see how to gauge through the how realistic that would be.
So I mean, I think you have to learn from the patients too, right? Not just
Mhm.
the clinicians. So from the patient's point of view, I'm certain that, travel can be a key part of their quality of life, especially after years of transplant. And you mentioned that in your study, you found a lot of them are going to visit family abroad, not just taking a cruise.
Right.
And finally taking, a big trip maybe they've postponed for years. I've heard this a lot. So how do your patients talk about travel after transplant? And is it more of a reward and celebration? So there's, less maybe anxiety about health risks, or is that kind of always present?
Yeah. I'd say from my personal perspective, I've seen a lot of people in clinic with the history of transplantation, and it's mixed. They understandably are very excited about being able to do to go on international travel after their transplantation. There's usually been a lot of talk with their transplant coordinators and their transplant team as well to make sure from a transplant standpoint that they're kind of ready to travel. But they, I think, are understandably and appropriately kind of risk averse and wanting to know what can they do to prevent infection during their trip. And so I think they approach it very logically and really want to have good guidance on what to do while traveling.
Great. So if a transplant recipient is listening to this and
Yeah.
is thinking about visiting a family member overseas or even going on that cruise, what's the first step you'd want them to take?
Yeah, I think first step probably would be to check in with their transplant team just to alert them to that wish and that desire to to travel in the future, and then even maybe suggesting to that transplant team that they may reach out to a travel clinic or ask about potential travel clinics where they could go to someone with that expertise in travel and the management of someone with an immunocompromising condition to be able to travel safely.
So I also want to touch a little bit on some things your study couldn't capture with the data. And so
Mm,
that's more like what comes next.
right.
So your data come from specialized pre-travel clinics, which probably represent a more risk-aware subset of transplant travelers. And prior work is suggesting that the vast majority of transplant recipients who travel never get pre-transplant care at all. So who do you think is missing from this data set, and how might that shape the patterns that we're seeing?
So, with this data set, we were seeing looking at people that specifically were going to travel clinics, and so with that, we're missing, people that either don't have the opportunity to get to a travel clinic, or patients that are unaware of the service itself. And so I think those that just don't have the knowledge that this expertise is there, or patients that may be vaccine averse or hesitant for vaccines to begin with would be populations in particular that we're not
Yeah,
targeting.
there's a lot of vaccine hesitancy
Right.
all around. So I understand that. So you also didn't have follow-up on outcomes like vaccine adverse events or travel-related illnesses, right? So if you did have that information, what what would you want to know the most about?
Yeah, I think that information would be very helpful and kind of in thinking about future studies. I think that not only doing the pre-travel visit consultation and what's being done then, but following up with the patients, maybe 10 days after to see what side effects did they have associated with vaccines, and then even after their trip, following up and seeing what infections, if any, they experienced during the trips as well. In addition to G10, I'm part of the GeoSentinel network, and so that's a network of health systems throughout the world that's really trying to leverage resources in kind of higher resource settings for the identification of emerging infectious diseases. And so, and that's the network where if patients come back sick from a trip, they're getting reported into that network. Again, because you have to get to that person that is it within the network to get reported to the network itself. You're still selecting for a population that's even potentially sicker or, being seen at one of these network centers. And so I think regardless, there's a lot of patients that would be missing. But I think a next study would be trying to enroll patients prospectively and then follow them through their travel to see how they do. I've had patients write to me after their trips, kind of thanking me for our discussion before the trip, and felt like what we discussed really came in useful, and they were very appreciative. Some even post-transplant have sent me pictures of their trips as well.
Well, that's amazing. I bet that feels nice.
Yeah.
Um, So you kind of already answered one of my next questions about future directions, but let me ask you, do you see any role for integration with transplant registries, or for decision support tools or EHR prompts that flag these transplant patients with likely travel plans and guides these pre-transplant and pre-travel vaccination?
Yeah, I think there could be some automation or decision trees that would be helpful with this process.
Okay. So is there anything else you want to add about the paper that we didn't cover or things that you would like the transplant community to know?
No, I think this is a very exciting aspect of post-transplant life for people. And so a lot of them are very excited to be able to travel again after this, as you phrased it, gift of life that they've been given with the transplant. And, through this process, I've been very appreciative for the mentorship that Regina LaRoque, Ed Ryan, and Camille Cotton were able to give me and continue to give me through our projects together.
Fantastic. So, we've been talking with Dr. Robert Wolf from the international travel after transplant world, and we've really been trying to understand travel patterns and vaccination practices and how they can improve pre-travel preparation and outcomes for these high-risk patients. The paper is titled Travel After Transplant: Demographics, Travel Trends, and Vaccination Practices of U.S. Immunocompromised Travelers, and it's published now in the Transplantation Journal. Dr. Rolfe, thank you for joining us and for shedding light on how we can support safer travel for our transplant patients. And thanks to everyone else for listening to the Transplantation Podcast. I'm Dr. Macy Levan, and we'll see you next time.